Good evening. My name is Amelia Langston. I'm the director of the Emory Bone Marrow and Stem Cell Transplant Program.
And hello, I'm Dr. Sagar Lonial. I'm the Chief Medical Officer at the Winship Cancer Institute. And today we're going to talk a little bit about cancer care during the novel coronavirus or COVID-19 pandemic and what our patients can expect during this time. We know that you have lots of questions on your own, so we encourage you to leave them in the comments section and we'll address them during this discussion as best as we're able. Dr. Langston, this is a difficult time for everyone, but especially for many patients with cancer. A question that comes up, at least on the top of everybody's mind, is are cancer patients at higher risk for getting sick from coronavirus, and what are some ways they can do to protect themselves from it?
So I think that's an important question. And the answer is that patients with cancer are significantly more likely to have serious complications if they acquire coronavirus 19. And so the best answer is to try to not acquire it. And we here at Winship are doing a variety of things to try to minimize the likelihood of our patients becoming infected. And first of all, we're counseling them on self-isolation because that's really the most effective way to prevent getting infected. But more than that, we're recognizing that some of our patients have to come into the healthcare environment, which can be a risky place to be right now. And so we're trying to minimize the traffic through our building and within our building by identifying the patients that actually really need to physically be here. And for some of the others, delivering their care in other ways, like telemedicine, telephone visits, and the like, so that the patients that come here are the ones that need to be here. We can better achieve effective distancing and keep people safer. We've also implemented screening at all of the entrances to our buildings. We've implemented universal masking. We're limiting visitors and practicing social distancing among our staff as well as our patients.
Yeah, I think that last point, those last couple points are really important in the sense that we have done what we can within our spaces to try and minimize the risk of exposure for patients by really screening our staff very carefully, screening anybody, as you mentioned, that come in and out of the building, and doing all those things. In addition, we've asked our healthcare providers and teams, when they leave here, to not go out and dawdle around town, to really go home and spend it mostly with their family in isolation there as well, to try and reduce the risk that they could be a vector of transmission of COVID-19 as well. So I think you're right. We've really gone to extraordinary measures to try and make when the patients have to come see us, to make it as safe as it can be for them.
Another point that I think is really important to think about, most of our patients, particularly our patients who are under active treatment, are very good at self-isolating already, but sometimes their family members may not be so mindful of that. And I think it's really important, particularly for people that you live with or that you come in contact with on a regular basis, for them to appreciate the fact that they protect their loved one, whether it's somebody with cancer or someone who's older and has comorbid conditions and is in increased risk for COVID complications. The best thing they can do is either self-isolate or stay away.
Yeah, no, absolutely, I agree. So there's a lot of talk, not just on the web, but also in social media about testing, access to testing, what's the right test to do. Can you talk a little bit about what we're doing, certainly at Winship and at Emory, from a testing perspective, and if patients have symptoms, how we can get them tested?
Sure. So it's a very confusing time now, and it literally changes by the day. But I think the standard test today for acute COVID infection is still a PCR-based testing, which is done in a medical laboratory. The turnaround on that test here at Emory is about 24 hours or less. There are some rapid tests out there that test in a different way, but we're not yet as clear on what the sensitivity and specificity of those tests are. Now, there's something else called serologic testing that has gained a lot of press over the last week or so. Serologic testing is testing for antibodies to the virus. And that's probably going to be very important going forward in terms of understanding the epidemiology of the virus and the spread of the prevalence of the virus in the community. But it is not a test to ask the question, am I infected? It's asking the question, have I ever been infected? And the other point that we still don't know is whether or not those antibodies that we detect with the antibody test are going to turn out to be protective, or if they are protective, how protective are they going to be? So there's lots of questions about this serologic testing right now.
Yeah.
Now, for our patients, for Winship patients, if they have symptoms, and symptoms meaning fever, cough, or shortness of breath, loss of taste, loss of smell, or even a sore throat coupled with fever, they can call here and we can get them tested. We have an oncology urgent care clinic that's handling our cancer patients specifically. And they come in, they can get tested, and for patients who test positive or who are under investigation, if they need other forms of care, like a blood transfusion or platelet transfusion, that's also a place where they can get their care until we sort out whether or not they have COVID.
Yeah, I think that's another important point, both to protect other patients as well as our staff and providers, is that patients that are symptomatic in any way or form that we know of, we move their care and investigation to a different area.
Right.
And that occurs not just in the outpatient setting, but also in the hospital. Patients with COVID that are admitted who happen to have a cancer diagnosis are not likely to go to the cancer floors, right? Do you want to speak about that?
Sure. We are trying to be very, very careful about who comes to our cancer floor. We're actually beginning virologic screening of our highest risk patients, our bone marrow transplant patients and patients receiving CAR T cells, because the stakes are so high. We don't want to take any chance that a patient goes into a procedure like that where their immune systems are going to be profoundly suppressed with COVID on board. And we recognize now that patients are not always symptomatic with COVID. So that becomes an important point. And for patients who are suspected or known to have COVID, they go to what we call cohorted units away from the other oncology patients, where they're kept with expert staff that are familiar with the use of the protective equipment.
So you mentioned sort of some of the things that we're doing to sort of screen for certain patients. We know, for instance, also that patients undergoing certain surgical procedures may have a higher risk of complications, or outcomes may not be as good. And so we're also beginning to screen some of them as well. Do you want to speak to that?
So there are two issues here. One is the risk to the patient of undergoing a surgical procedure in the context of having the viral infection. Obviously, we don't want that, particularly if we're talking about a big surgery that's going to have a prolonged recuperation, and anything that involves the respiratory tract is a high-risk procedure for sure. But the other issue is the risk to healthcare providers because of the need for a big procedure to do general anesthesia, because one of the highest risk procedures for the healthcare provider is anything that causes the patient to expectorate, like putting in an endotracheal tube. So it's also for the protection of the anesthesiologist and the surgical staff that many of the patients for our highest risk procedures are being screened.
Yeah, no, I think that's, again, it's all about protecting the team, protecting the environment, and minimizing risk for many others as well. So let's talk a little bit about what patients should consider in terms of visiting with their oncologist and or treatments during coronavirus. I think one of the challenges that we in cancer therapy really struggle with is that it's easy to cancel and say we don't need to do elective office visits or elective surgeries. but cancer often doesn't wait. And so what's sort of a strategy from the outpatient setting that patients should think about employing when they make visits to the office?
Well, I think a lot of the question of necessity of visits really falls to the healthcare team to decide how best to deliver therapy most safely and whether or not the therapy is really urgent and time sensitive. So, for example, for some of our therapies, we've changed the schedules so that treatments are delivered every month instead of every 2 weeks, just to minimize visits to the clinic. There are certainly some treatments, particularly treatments for some of our aggressive hematologic malignancies and some of our diseases that are very, very curable, where we feel that they are time sensitive and that that it really does have meaning whether to continue therapy. And in that situation where we think it's going to be life-threatening or life-prolonging, we're not necessarily canceling therapies. But I think in preparation, if a patient is going to be continuing therapy, they need to be, during this epidemic, they need to be very mindful of the self-isolation procedures and protect themselves, and their families need to be very mindful of protecting their loved ones.
Yeah. So I think, one of the things that a lot of patients may not completely understand, at least, or appreciate is the algorithms we go through to make decisions on timing of treatments or visits or laboratory testing. And so I'll break those down really briefly. And at Winship, we really broke it down into 3 categories. The first category is that medically necessary to continue at the current schedule, at the current dose, however you want to phrase that, but that delays would not be medically appropriate. The second category was situations where clinically we felt that delays of 2 to 4 weeks would be safe and medically appropriate. And the third is delays beyond 4 weeks, where we felt, again, it would be medically safe and appropriate to either delay that therapy or delay that visit for at least a month. And those 3 categories have really been an important guiding principle for what we've done throughout Winship, whether it's surgery, whether it's radiation, whether it's infusion, whether it's hematology, or whether it's solid tumor oncology. All of those really are important ways to consider how we think about imaging, lab work, and treatments. And I think that that's a really important way to provide that information to our patients.
I think one of the, if not to put a happy face on a difficult situation, but I think one of the silver linings that has emerged from this epidemic is the implementation of much more in the way of telemedicine. And I think we are really learning that many of the things that we have historically done in person can very, very easily be done through telemedicine visits and the like. And I think that's something that is likely to continue to be a pattern in our care going forward, even after we emerge from this COVID-19 epidemic. And I think that has implications for patients and their general quality of life and ability to continue living their normal lives, and also I think has implications with regard to health economics and space utilization and lots of different things.
Yeah, no, this is great. And to the audience, we've got one question right now from the audience, but please go ahead and send your questions in now because we've got time to really try and address them. Dr. Langston, let's start off with the first. You mentioned self-isolation earlier. How much should I stay home? What can I do if I'm at home? And my husband still works. Should we be concerned? Or what can we do to minimize his risk of bringing COVID into the house?
Well, I think probably the most important aspect of that is awareness. If a person has a loved one at home who is in a vulnerable category of people, whether it's cancer or some other vulnerable category, I think it's important that that person actually structure their work to be as socially distanced from other people as possible, and pay close attention to the things they touch, the places they go, and the like, and to really minimize their person-to-person contact with others while they're at work. If it's possible for them to telecommute, that's always a great option. But if they have to go outside the home, then I think they really need to make their coworkers aware that that everyone needs to be very careful.
Yeah. I think the other piece is we know that many of our colleagues who are healthcare providers that are on the services taking care of these patients in the hospital basically either dress or undress before they come home. They
Right.
decontaminate out on the porch, with washing their hands and doing all those kinds of things. I don't know that for somebody whose spouse is still working, you need to go to that level of decontamination, but certainly being incredibly cautious, I think, is important.
Agree.
Yeah. Okay. So how long after chemo are we considered immune compromised? So that's a broad question because I think it depends on what you get, but why don't you try and tackle it?
I think that's a much too broad question to have an easy answer to, but I think that my sort of brief answer would be that for at least the first 6 months after receiving chemotherapy, you should consider yourself to be immune compromised, and it may be much longer.
Yeah.
And we also know that even patients who have a history of chemo in the remote past are at increased risk for complications of COVID. So you're not off the hook just because your chemo was a year or two ago. You still should consider yourself to be at increased risk for complications and should still follow the same social distancing rules that we've talked about today.
Yeah. And I think it's important nowadays, particularly where many of the treatments that cancer patients receive are not traditional chemotherapy. And I think if you're receiving, pembrolizumab or one of the T cell activators, if you will, I don't know necessarily that your risk is going to be lower than it would be in somebody getting traditional cytotoxic chemotherapy. So even if you don't feel sick from the treatment you're getting, you're probably still at higher risk.
Yeah, and I think you touch on an important point, and that is that we have many of these so-called biologics now that may take the form of a pill for, imatinib or other things like that that we don't necessarily think about as being immunosuppressive, but many of them really are. So if you are on treatment, you should really consider yourself to be at risk.
Yeah, I think that's important. So we've got another one here. I have it says bone biopsy. My guess is marrow biopsy in May and labs, but lives 75 miles away. Should I reschedule? I think that's something probably worth discussing with your care team, maybe a week or so before the procedure and the labs are scheduled. While we are trying to minimize exposure, sometimes there are things that you need to do as part of the treatment process or the evaluation process that can or can't necessarily be delayed on a simple timeline. So I don't know if you want to add anything to that. All right. So we've talked a lot about sort of the impact on cancer. Let's talk a little bit of sort of what's out there from a treatment perspective, because ultimately, until we have a vaccine or until we have treatments to make this manageable, we're going to continue to be a little bit on pins and needles. So can you talk a little bit about what some of the encouraging treatments are out there? You can skip the chloroquine and hydroxychloroquine because I think that's very suspect, especially given recent data. But talk about some of the really promising stuff that's out there.
Well, I think probably one of the most exciting areas right now is in the antivirals. And remdesivir is an antiviral that we have here at Emory and is being tested at other sites as well, and is fairly far along in its development and is showing some preliminary data suggesting activity against COVID-19. There are some other novel antivirals that are less far along in their development, including a couple that were developed here in a drug development lab in the Department of Pharmacology. Whether those will make it into clinical trials during this wave of this epidemic is a little unclear, but there are some other antivirals under development. Obviously, we would like a vaccine, and we would hope that within the next 6 to 12 months that might be ready for at least large-scale clinical trials. But right now, we're still really in phase 1 of development there. There also is another sort of a hypothetical sort of type of treatment that has been tested in Europe and in China and is coming into clinical trials here in the United States that involves blocking of a molecule called IL-6, which is an inflammatory molecule that is thought to be involved in the response to the viral infection that leads to some of the serious manifestations like respiratory failure. I think it would be premature to say whether or not these strategies are going to be successful, but they are in clinical trials, and we hope to have a clinical trial here at Emory using this strategy in patients with pneumonia from COVID-19.
Okay, yeah, so there's certainly a number of exciting molecules that are coming down the road. I know that there was one that our famous pharmacologists have actually developed as well from a preclinical model that I think is being tested in phase 1 here also. So I think there's some exciting stuff that's coming down the road. All right, so here's one right up your alley. How long after a BMT is one considered at higher risk?
Well, the first issue is what kind of a BMT. We have autologous transplants using one's own cells, and that certainly is a less immune suppressive endeavor altogether. The more prolonged immune suppression occurs when one receives an allogeneic transplant using a donor. But I think the bottom line is that in either case, you should absolutely consider yourself to be immune suppressed for at least the first 2 years after the procedure, and for patients receiving an allogeneic transplant, probably for longer.
Okay.
So a person who's had a transplant should really consider themselves at high risk, period.
Yep. All right. So what do I do if I think I've been exposed to or have the virus? So let's presume this is one of our patients. What are their instructions? Because the question that always comes up is, do I go to the emergency room? Do I not go to the emergency room?
So the emergency room is probably not the place that any of us want to be right now. I actually avoid riding my bike right now because I don't want to break my arm and have to go to the emergency room, because that's where the COVID patients are. So if you believe that you have been exposed and you don't have symptoms, the guidance for non-healthcare professionals is that you should self-isolate completely. You should quarantine yourself for 14 days from the time that you think you have been exposed. If you develop symptoms as a cancer patient or a non-cancer patient, you should, at this point, seek out testing. If you're a Winship patient, you can certainly be tested, as we talked about before, through our oncology urgent care clinic. But that helps us to know and to be able to monitor you effectively if you have COVID, so that we can see you through the infection and take appropriate measures.
Yeah, I think that's a really important point. If you're obviously short of breath or in what we would call extremis, meaning low blood pressure and you can't get up or weak, then the emergency room is perhaps the right place to be. But in the absence of those kind of extreme symptoms, we'd rather you check in with us to help us guide you to the best and safest place to be able to get care in a way that does not necessarily expose you to higher risk. So there's another question. I have scans coming up. Will they be delayed? Also, my follow-up has been canceled. Will I have it via video conference? I think, honestly, those are best dealt with by calling your care teams, because many of the scans are being moved based on where we think we're going to do the follow-up. And some of that follow-up may be done by video conference. If the team feels it's appropriate that you actually come in and see them, then that may be the way that they go. A lot of it is really dependent on we're leaving it to the local level to address some of those questions, I think.
So Dr. Lonial, I have a question for you. What does life look like after we get past this surge that we're expecting of the COVID virus infection?
Yeah, I think, that's a really hard question. And we see all these things about Los Angeles isn't going to have sports events or open air concerts or things for 2 years. I think a lot of it is really going to depend on the general prevalence of the protective antibodies and how protective they really are. The number of infections that you see on the news every night may not accurately reflect the true number of people, A, that have been infected and symptomatic, or B, that may have immunity because they had a small infection that didn't really get that symptomatic. So I think the serologic testing that you mentioned at the beginning is going to be really important for us to be able to understand how prevalent is the protection, and that will likely guide how draconian the measures need to be in the post-COVID era, because if 30 or 40% of the population has seen it one way or another, that's a different discussion than if only 5% of the population has seen it.
Right.
So I think it's going to be a lot of details and additional testing, and probably broader testing for the larger population to help figure out what's going to be safe and what's not going to be safe. So.
Yeah, I think that's a really important point. There's this concept called herd immunity. And what it basically means is that by other people in the community being immune, that effectively protects you. And that's very much why the influenza epidemics that we have every year are so self-limited, because enough people have had the influenza vaccine that it limits the spread of influenza effectively, because you have the herd protecting those who don't have immunity.
Okay.
Right now, we have no herd immunity, very little herd immunity to coronavirus.
So here's another one. I'm on treatment, and if a vaccine is available, how safe would it be for me to be around my family? I think maybe that's considering that it might be a live vaccine versus an attenuated vaccine, or would either of those impact safety around people that have been vaccinated?
The only safety issue would be if it were a live vaccine, and I think it is extraordinarily unlikely that the COVID-19 vaccine that comes out will be a live attenuated vaccine. I think it's much more likely to be some sort of a subunit vaccine that's genetically engineered.
Yeah, and I think the other question is, for people that are on or have just completed treatment, how effective is the vaccine going to be in those patients compared to sort of normal hosts, if you will, because we don't know how long that vaccine effect will last in somebody that's in the midst of treatment, for instance.
Right. And those are questions I think we have no answers for. We struggle with these kinds of questions in our bone marrow transplant patients with just regular old vaccines.
Right.
And sometimes we will utilize more aggressive kind of prime boost sorts of strategies to try to effectively boost their immunity in circumstances where we think they may not have as good a reaction to a vaccine as we would like.
Yeah. So the next one is this is a myeloma one, I'm guessing. 5 years post-transplant in VGPR, still on Revlimid. Am I immune deficient or compromised? I think the answer is you probably have some level of immune deficiency. There's been a lot of talk in the myeloma community about whether Revlimid or lenalidomide, through its effects on activating T cells and NK cells, might actually be somewhat protective for patients. We don't actually know the answer to that, but certainly in patients who are not having side effects or symptoms, we're recommending that they continue on Revlimid, but try and really practice a good social distancing and isolation until we get past the pandemic wave, I think. All right, so I think we've got just a couple of minutes left here, and I think we've covered a lot of the important issues that we wanted to discuss during this time. Dr. Langston, any sort of parting words or last thoughts for patients that are watching this before we wrap up?
I would just reaffirm the fact that the best thing you can do right now is stay at home, particularly if you are in any kind of a vulnerable category. And the best thing that you can do for your loved ones, if they are vulnerable, is to either stay home or stay away.
Yeah, I will tell you, I've been struck by how low the frequency of our cancer patients have been testing positive for COVID-19. Yeah. And I think, to me, what that really says is they've really taken this message of isolation and social distancing to heart, and far more so than others in the general population. And I think that's
Right.
I think that's really made a big difference in why we've not seen the frequency of patients that I think many of us had been expecting or were worried about us being able to see. All right. Well, thank you everyone for joining us today. We ask that if you're feeling sick or have a fever or cough, please contact your oncologist and care team for guidance before coming for your appointment. For Winship patients, please call 404-778-19 or message through the patient portal if you develop symptoms, and we will direct you regarding next steps on how to get tested, how to get evaluated, whether or not you need to come in, if you do need to come in, where you need to go, so that we can not only maximize your chance of getting a good outcome, but also protect the most number of people in the healthcare system, because there still are a lot of people providing frontline care to cancer patients at Winship. Dr. Langston?
Good night.
All right. Thank you.